So for everyone else, I will talk now in English, and I want to welcome everyone to this international call. We are happy to inform you that you can listen in German, in Slovenian and Hungarian, and you just go down at the bottom where you can see the globe, and you click there and you find the different languages. Today, we are really happy to be joined by Dr. Paul Clayton. He has been in Europe for a while. I just landed in US, so he is a bit, he has traveled a long way, but he's still with us. And what I really admire about Dr. Paul is that he has now for 40 plus years been a leading expert in nutritional science. And he has been having his summa cum laude graduate in Edinburgh University with a PhD. He is the former chair of the Forum on Food and Health at the Royal Society of Medicine. And also a former senior scientific advisor to the UK government's Committee of the Safety of Medicine. So his works connects diet, gut microbiota, inflammation, and metabolic health. And two of his books, Let Your Food Be Your Pharmaconutrition, it's actually in Norwegian, translated in different languages, and also How to Regain and Maintain Your Health, turns really complex science into everyday routines for us. That's what I really admire and appreciate about Dr. Paul. At Cincino, Dr. Clayton advises on test-based health and help us understand markers like the omega-6, omega-3 balance, and now also a lot about gut-related metabolites. Today, he will explain why the gut microbiota is a central control hub for immune function, for metabolism, and inflammatory balance, and why the Cincino Gut Health Test is a precise tool to reveal personal imbalances and also help us with plan data-driven actions. So we are very honored to have you on our call tonight. Please welcome Dr. Paul Clayton.
Well, thank you. The honor is equally mine. It's a pleasure to see so many people in the audience. And I see a number of doctors who I'm delighted to welcome into the conversation. I'm going to show some slides to back up the points that I want to make, because gut function is quite complicated, and I think some pictures and some bullet points are going to help to get the overall message across. So let me see, first of all, whether I can do this. So I want to talk today about why it's important, what happens to the population of microbes in the intestine, how it affects not just the brain. We all know about the gut-brain connection, and I will talk about that, but every other tissue as well, through a number of different connections, through the vagus nerve, through the bloodstream, and speaks to all of these other tissues in many different languages. And I'm going to talk about how we can test for this stochastic system. It's very nonlinear. It's affected by many, many things, and there are multiple outputs. And so there are some questions as to how can gut function and gut health most accurately be tested. What should one measure?
Excuse me.
Yep.
Jetzt kommen die Teilnehmer rein. Gib noch 2 Minuten. Es kommen
Paul,
jetzt
they have
gerade
managed
800.
to upgrade the Zoom room, so there are more participants joining. So
I
the
see.
numbers are getting higher now.
Okay. Do you want me to? Shall I just continue?
Yeah, you can just continue or start. It's still counting.
All right, let me start again.
Yeah.
All right. Well, thank you to everyone who has joined. If there's time, I hope that there will be sufficient time for you to ask questions at the end. And perhaps I should start by asking the question, how should one measure gut health? If there is no single, simple way of measuring gut health, and this is an extraordinarily complex system, how can we legitimize choosing a set of analytes and using those as proxies for overall gut health? Why is that relevant? Why is it important? I'm going to try to explain how gut health connects to so many other things in our bodies, what form these connections take, how our historically very abnormal diet has prejudiced these connections, and through these connections, our health in so many ways. And then I'll talk about how I think we can put it right and how we can measure this shift. Now, first of all, I think I need to point out that the gut, really almost every physiological system in the body, is extraordinarily stochastic. These are not linear machines that we're talking about. This is not just another, like a Porsche or some crude piece of machinery like that. The human body, in fact, most life forms are so much more complex. They're so much more iterative, more recursive. And you don't usually put a single input in and get a single output out. What happens in the gut is affected by many different factors. What you eat, your moods, your overall level of stress, your use of recreational drugs, which may range from alcohol and nicotine all the way across the very increasingly wide spectrum of the other pharmaceutical tools that people play with in their spare time. And out of the end of all of this comes a set of parameters which between them define gut health and gut function, which may lead to functional and positive behavior in the gut itself, or negative behavior. It may lead to negative outcomes in the gut and in associated tissues, and even in tissues which do not appear to be gut associated. It's complex. So I'm going to try to take a very simple path through this very complex arrangement. And at the end, hopefully, I'll explain to you how we have ended up by choosing a relatively small number of analytes or markers to give us an overview of gut health and how it changes in response to different interventions. So everybody knows about the gut-brain connection, but in fact, the gut connects to absolutely everything, and I'll review a few of those in my talk. But I want to start with this old fellow, who's of course Hippocrates. You may recognize him. We're going back 2,000 years to the golden age of Greece, and Hippocrates famously said that all disease begins in the gut. Well, he said many other things, some of which are correct, some of which probably are not. And when he said that all disease begins in the gut, I don't think he was correct. Disease can start in many other tissues. But what he actually did realize through empirical observation was that when things go wrong in the gut, this can lead to many adverse symptoms appearing in many other tissues. So in many respects, I think that he was, at the very least, partially correct. I think that now we can reinvestigate Hippocrates' concept by looking at the genome. Humans actually don't contain a huge number of genes. We're between 20 and 25,000 genes determines a great deal of who and what we are. I'm not going to talk for the moment about environmental issues with nature as well as nurture as well as nature, but 25,000 genes seems to be enough to account for the enormous variation that you find in human beings, phenotypes, their different abilities, their different health and disease profile. When you compare that to the numbers of genes utilized and owned by the microbiota, that is the number of the colony of microbes that live inside you and on you, it's far, far greater. That's something in excess of 12 million genes. So there's a great deal more diversity in the microbial population, not just bacteria, but also viruses, phages, molds, and various other microorganisms, single-cell organisms. And then the next question you really have to ask yourself is, what are these genes doing? Well, between them, cumulatively, they account for significantly more than 50% of our metabolome, significantly more. But those genes, what they're actually doing is they're coding for proteins. And some of those proteins are structural, but many of them are enzymatic. And they're coding for a bewilderingly wide range of metabolic reactions. The bacteria are producing an incredibly complex soup of chemical compounds in the gut. Now, we have outsourced some of our metabolism to those microbes. That we find it useful to do that. It's presumably more efficient to have these microbes perform some of our metabolic activity, but it is a Faustian bargain. Those microbes are producing wide ranges of compounds, very many of which are not good for us at all. Some are essential, a small number are, some are helpful, but very many of them are potentially extremely harmful to us. So what we have had to do is to develop a colonic epithelial barrier system, which keeps this very complex and potentially extremely toxic soup of microbial compounds in the intestines, and therefore outside our body, topologically speaking, but retains and allows transit to those compounds, microbial compounds, which are potentially helpful. So this is not any crude filtration system. It is a very selective barrier. It's keeping out from the body those things which could harm us. In an ideal world, theoretically, that's what it's supposed to be doing. And it's allowing ingress to those compounds that we require and which are important to our health. It's very clear that the healthy microbiota are essential for our health. Germ-free animals have all kinds of problems of their own. And we know now that in order to maintain a microbiota that is more healthy than unhealthy, you need to have a significant component of prebiotic fibers in the gut, which feed saccharolytic species. Saccharolytic meaning that they consume carbohydrates, and that is what prebiotic fibers are. When you look at their structure, you can see that they are all carbohydrates. There are really three different types of carbohydrates, which we can refer to here. There are the digestible carbohydrates, sugar and starch, which are digested and absorbed in the small intestine. There is a small number of structural carbohydrates, which some of them are actually sampled in the small intestine and then have a modulating effect on various aspects of our immune system. And the third group, and that's what I'm going to talk about here, are carbohydrates which are not digested. They are not sampled as whole molecules. They are fermented by the saccharolytic bacterial species, which mostly live inside the large intestine. And what we have come to realize, there's been a whole proliferation of preclinical and clinical studies over the last 20 years or so, and they're rapidly increasing, which shows that having a significant amount of prebiotic fiber in the diet is not only essential for gut health, but really for the health of just about every other physiological system in the body. And the importance of these fibers was brought out by a very large meta-analysis that was conducted on behalf of the WHO in 2019. And what this meta-analysis demonstrated, I think, to everyone's satisfaction, is those people who consumed higher amounts of fiber intake in the highest quintile of fiber intakes, early death, which really means preventable death, was reduced by 30%. So these fibers are very, very protective, very important for your health prospects. And how are they important? Well, they reduce the risk of bowel cancer, and I'll return to that later on, breast cancer through mechanisms that we now actually begin to understand, huge reduction in overall cardiovascular and cerebrovascular risk. And more recently, there's been further data coming out which shows an equally significant reduction of risk of the dementias and in what we used to know as NAFLD, the non-alcohol related fatty liver disease, but we now talk about metabolic disorganization. New data as well coming out indicating that these prebiotic that fibers, and in particular prebiotic fibers, reduce the risk of Parkinsonism. I think this had been known for some time, that the microbiome somehow modulated the risk of Parkinsonism, as it was known that back in the days when vagotomy, sectioning the vagus nerve, was once upon a time a rather brutal but reasonably effective treatment for peptic ulcer. It was found that in those subjects who had been treated with vagotomy, the reduction of risk of Parkinsonism, the subsequent reduction of risk, was highly significant. And here again, we have a developing idea as to what this link is. There are a group of bacteria in the microbiome known as desulfovibria bacteria. They reduce sulfates in the diet, forming H2S, hydrogen sulfide, which not only smells bad, it's also very irritant, very corrosive, and it is a grade 1 carcinogen. And we now know that it is involved in the formation of various bacterial malfolded proteins that appear to be able to travel up the vagus nerve and induce neurotoxic effects in the caudate nucleus and other parts of the dopaminergic system, which we know is degraded in Parkinsonism. So this is an extraordinary degree of protection conferred by what appeared to be a relatively simple group of nutrients. And more recently, again, just within this last year, a group of French and Italian researchers showed that in those people who consumed the highest intakes of prebiotic fiber, the deep markers of healthy aging were increased by about 30%. So these fibers are important, very, very important to your continuing health and well-being. These are the saccharolytic bacteria. Some of them are very familiar. I think everybody knows lactobacilli and the bifidobacteria. We put these into yogurts. We drink them in kefir. We swallow them in capsules. Not that that's a particularly effective way of taking them, but there's many others. These are some of the other saccharolytic bacteria, probiotic bacteria, which are associated with positive health outcomes. They have a certain number of things in common, apart from consuming prebiotic fiber in a fermentation reaction. They produce various short-chain fatty acids, and of course, you've heard of butyrate, I think, but propionic acid is another short-chain fatty acid, which is produced by these bacterial species, which has positive metabolic effects of its own. And they produce a compound, which I'll come back to when we start talking about the test, called indole propionic acid, which is a very interesting compound indeed. That's not all. The microbiome is producing a very wide range of compounds. They produce compounds which modulate our immune system, which encourage the development of foam cells in the artery linings if you don't have the right bacteria. The good bacteria are producing bacteriocins, which are interesting to us because the more you feed the good bacteria, the more they produce these bacteriocins, which are used for close quarter combat. That's how the probiotic species gain their place in this very competitive milieu of the lower intestine. The good bacteria are producing these compounds, and that they actually kill off other microbial species that we think of are not being very good for us. They produce pathogen-associated molecular patterns and various other rather complex molecules which modulate the immune system, both in the gut-associated lymphoid tissue, the GOLT, but also systemically. And they produce microsomal mRNA, which we now are beginning to think may have programming effects on tissues quite remote from the gut. And some of these, which are present in exosomal form, may actually be a mechanism through which we may develop tolerance of those people around us. These exosomes are acting as biological emissaries, if you like, explaining us to each other, to the people who are close to us, in a way that makes it easier for us to tolerate them in the sense of not reacting negatively immunologically towards them. So here you've all seen these pictures. If you eat lots of prebiotic fiber, it enters the large intestine and it's in the lumen of the intestine. So the saccharolytic bacteria are coming to get their food. They move into the center of the lumen. They're not at the edge of the lumen because we don't really want too many microbes in intimate contact with the colonocytes, that is our cells that line the gut wall. And there are the little green dots there. They're consuming prebiotic fibers. They're producing all kinds of interesting compounds. And I'll come back to some of these in a minute. And that creates an environment in the gut which is anti-inflammatory and which is very chemoprotective. So these bacteria are producing compounds which, amongst other things, modify the T cell population of the GOLT in a way that actually makes it easier for the gut to identify cancerous cells and suppress them. Now, there's all kinds of cancerous cells around all the time. We now talk in terms of cancer ecology. When you look for cancer cells, you find them in every tissue. There's lots of them, but they're held in check. There are far more potentially cancerous cells than there are cancers. That is because these proto-cancerous cells, if you like, are being held in check by a raft of influences produced not only by other normal cells, but also by our microbiome. One of the important tools that we use to maintain health and to prevent cancer is through a healthy microbiome, which is producing, amongst other things, butyrate. And we'll come back to that. So what's happened to our intakes of prebiotic fiber? Well, we've stopped eating it. I don't think we really understood how important these fibers were. They were thought of as bulk, as really such simple starches. We didn't need them. We could get by without them. The WHO study shows that that's not true. And I want to show you how our intake of prebiotic fibers has declined. We have quantitative archaeological analytical studies from Mesoamerica that indicate that 2,000 plus years ago, people were consuming probably 20, maybe even 25% of all their calories in the form of prebiotic fiber, roots and shoots and maize, beans, and things like that. Nopales, if you've ever been to Mexico or Central America, you'll know what they are. They're consuming really a lot of fiber. So they have a microbiome that is largely, it's predominantly saccharolytic, and their gut is highly anti-inflammatory and very chemoprotective. We don't know how healthy they were. In order to see what the effect of this on health might be, we have to come closer to the present time. Now we're in the 19th century, at a time when society is beginning to document itself in great detail. The mid-Victorian period, which I've studied and write about, at that time, prebiotic fiber has fallen considerably. It's about a third of, or maybe a quarter of what it was. And it's from different sources, but it's now between 20 and 40 grams of prebiotic fiber a day. What effect does this have on their health? Well, I can talk about Victorian health in a number of different ways. Their gastrointestinal health was certainly better than ours. Having studied the medical textbooks of that time and a lot of medical records, it seems clear that IBS was not known, did not occur at that time. IBD, barely recognized, possibly one or two cases here or there, but it's extremely rare. Colorectal cancer, and this is a cancer which is growing quite rapidly at the moment, especially in the young, was known then, but it was rare, and it was so rare that the doctors of the day, even without the ability to test their patients genetically, they could see that colorectal cancer was occurring only in families. At that time, colorectal cancer only occurred if you had a high risk denoting gene. Of course, these days, everyone is getting colorectal cancer, and this huge decline in prebiotic fiber may have something to do with it. In fact, I'm pretty certain it does, because when you look at prebiotic fiber intake today, in North America, the intake of prebiotic fiber is down to between 3 and 4 grams. So it's become negligible. The European profile is probably a little better. It may be twice that. We may be consuming 5 to 6 grams a day. But compared to historical norms, this is very abnormal. So, and of course, we have lots of IBS, lots of IBD, lots of colorectal and appendiceal cancer, lots of MASLD, and I'll come back to that. So in historical terms, and I think in order to understand where we are now, you have to know where we come from. Traditionally, the microbiome would have been dominated by saccharolytic species. And if you have a lot of the saccharolytic species and you're feeding them what they need, they're producing bacteriocins, and they are suppressing the numbers of bacteria which consume protein and or fats. Now, these bacteria have now begun to become much more numerically important. We're not feeding the saccharolytic bacteria. Their numbers are declining. So the other bacteria, nature abhors a vacuum, are multiplying and increasing in the ecological space that has now been made available for them in the large intestine. And many of these, not all, are gram negative, and that's important, and I'll come back to that in a minute. Now, I mentioned a moment ago how rare colorectal cancer was in the 19th century. In fact, the chronic degenerative diseases as a whole were much less common then than they are today, occurring at only about 10% of the levels that we see now. And as the WHO studies showed, the extent to which high intakes of fiber protected against cancer and vascular disease and dementia, could there be a link? Could this huge increase in non-communicative degenerative disease, could it be related to this catastrophic decline in our intake of prebiotic fiber? Well, there is your healthy gut. The prebiotics are gone. So here are the proteolytic species, the lipolytic species. What are they consuming? Well, proteins and fats. Where do they get them from? Not from your food, because the proteins and fats that you consume are being digested and abstracted in the small intestine. So these bacteria, if they're left to their own devices, they will obtain proteins and to some extent lipids from your gut lining, particularly from the mucus that lies over, that's the pale yellow lying over the cells, which protects them, which consists, it's a very hydrated protein gel. The proteins are called mucins, and the bacteria that start to multiply, if you no longer eat prebiotic fiber, they consume mucins, the mucin proteins. And so the mucus layer that should normally be there to protect your cells is eroded, it's broken down, it's consumed. And these bacteria, those little red dots, they're now coming into direct contact with your cells. And I come back to the fact that many of these are gram negative, which means they're coated with lipopolysaccharide, which means that this now creates enormous chronic inflammatory stress. So now the cells that line the colon are profoundly inflamed, and many of them die. Many of them will become cancerous, far more of them than if you'd been eating a healthy diet. And they're sending out messages to other cells, both in the gut wall, but also through the portal circulation. They're talking to the liver, the rest of the vascular system, and every other tissue. Now, they are now producing large amounts of LL37 and interleukin-1 beta. And that's not a good situation, because we know that an excess of LL37, which is actually a cathelicidin, which is one of those bacteriocins I told you about before, one of those weapons that these bacteria use to fight each other with, that has now been rather profoundly implicated in the progression of coronary artery disease, cardiovascular disease, and interleukin beta excess has been linked to chronic inflammation elsewhere in the body, and also to increased progression of tumors. So this is not a healthy configuration at all. We need to get back to the Garden of Eden. We need to have a lot more prebiotic fiber in our diet. We need to restore saccharolytic dominance in the gut. Where have we gotten to today? Well, I said IBS didn't exist in the 19th century. IBD, probably not either. Very little colorectal cancer. Where are we now? Well, IBS now affects up to, again, the figures are confusing. And you need to look at lots and lots of different studies, surveys in different countries. I would say that it's about maybe an average of 10 to 14% in all the different countries where these figures are produced. So a lot of IBS. We know that pediatric inflammatory bowel disease is rising in most countries. And in adults, it's already at quite a high level in many countries. But in those countries where they are just starting to industrialize and they're starting to go through this dietary shift from natural foods to ultra-processed foods, which involves a cataclysmic decline in prebiotic fiber intake, we know that adults in those countries where the dietary shift is now occurring, we see the rates of inflammatory bowel disease rising very rapidly. We know that SIBO is increasing. Now, how does that connect? Well, different causes, different major risk factors for SIBO, and I won't talk about all of them, but one of them is if you have inflammatory bowel disease, we're leading to cicatrization, scarring of the lining of the lower gut. As and when this involves inflammation and then scarring and deformation of the ileocecal valve, this valve no longer operates properly, so that the peristaltic waves, which would normally push the contents of the gut from proximal to distal, if the ileocecal valve is not functioning properly, if it is not patent, then these peristaltic waves can push material from the large bowel up into the small bowel, carrying bacteria with it, and we may have the ability to host those bacteria in relative comfort in the large bowel. Once they're in the small bowel, which is not their natural home, if your diet then contains other compounds which those bacteria can use, and they multiply and produce short-chain fatty acids and gas and other things in the small intestine, which is not as good at distending, now you have discomfort, now you have pain, now you have SIBO. And then, of course, I'll come back to this colorectal cancer thing. I think that many cancers are increasing in young people. By young, when people talk about young in cancer terms, it's generally under the age of 50. And many of the important cancers are increasing in frequency in this group, colorectal cancer in particular. And you can see here in the slide just how significant that increase has been. Here is the same thing in graphic form, which looks pretty frightening. The same thing is happening to appendiceal cancer, which is less common. But if anything, the increase here has been even more dramatic. Now, what's happening in the lower intestine, a bit like Las Vegas, it doesn't stay there. You have the portal circulation. If the epithelial barrier has become degraded through the wrong microbiota, through chronic inflammatory stress, through the epithelial barrier breaking down. A lot of these bacterial toxic products are going straight to the liver. And this is one very important reason why the numbers of people with metabolic with metabolic dysregulation associated fatty liver disease and its more severe complications, steatohepatitis, and some of the important liver cancers, why they're all increasing. But MASLD currently affecting almost 40% of the world's population, and on current trends, 50% by the year 2035. Now here we have data coming in, which refers back to that WHO paper, more fiber is better for you. And now there are studies coming out which show that adding prebiotic fiber to the diet is protective against colon cancer, a couple of studies to show that. And it's hepatoprotective as well. So these are two, I think, very persuasive reasons to increase your intake of the right mixture of prebiotic fiber. I talked about dementia as well, how a high fiber diet was protective against dementia. How could that be? Let's talk about neurodevelopmental disease, and we'll talk about affective disease and neurodegenerative disease, not necessarily in that order, but I'll go through all of them. We know that the neurodegenerative diseases are increasing in the developed nations, and we know, and I've only put schizophrenia in because according to DSM-5, this is now being regarded as a late onset neurodevelopmental disease. Okay. So what are the risk factors for neurodevelopmental disease? Well, almost all of them involve chronic inflammatory stress. And there was one very beautiful preclinical study in which rodents, pregnant rats and mice were exposed to interleukin-8, a potent inflammatory mediator. And the offspring, the F1 generation, manifested a very high incidence of those symptoms which we would translate as neurodevelopmental problems. So the preclinical work, I think, is rather good, and there is some clinical epidemiological work that's beginning to come out which shows the same thing. Endotoxemia, which is what happens when you have the wrong microbiome. You've got a leaky gut, you've got toxins leaching into the blood, including the lipopolysaccharides, which I talked about before. Once they get into the bloodstream, they're causing low levels of chronic inflammatory stress within the cardiovascular system, but in every tissue that vascularizes. There's also a vasopressin link, which is rather interesting. The microbiota has an impact on vasopressin metabolism, and there is very new data coming out that shows that disturbances to vasopressin metabolism also seems to be very intimately involved in the development and progression of neurodevelopmental disease. So there's another mechanistic link here, I think a rather persuasive one, between dysbiosis, inflammatory stress, and an increased risk of neurodevelopmental disease. There is evidence, not, I wouldn't say it was conclusive, but in growing and persuasive evidence that prebiotic fibers will reduce the risk of neurodevelopmental disorders if you have a diet which contains more of these fibers and consume that during pregnancy. That looks as if it's going to be significantly protective. Then the affective disorders. We know that certainly depression and anxiety states are increasing in incidence everywhere you look. I don't want to be too reductionist about this and say it's all due to diet. I think that the social media create a very destructive echo chamber for our young. I think that given the stupidity and corruption of the political class, people have good reason to be anxious and depressed. But I believe that there is a nutritional and therefore a metabolic substrate to this as well. Particularly when you look at rates of reported pain, chronic pain. Now, chronic pain, the figures for that, again, a little bit messy, but it certainly looks as if this is increasing in adults. There's evidence that this condition is increasing in children as well, which indicates probably a combination of neuropathic and nociplastic pain, all of which we know are driven by endotoxemia. if the endotoxemia is bad enough, you actually start seeing nerve cells being damaged and then dying. So you really don't want to have too much of this lipopolysaccharide circulating in your bloodstream, but you will do if you eat the modern diet, which leads to a leaky gut. Lots of proteolytic species causing inflammation, breaking open the barrier, leaking their lipopolysaccharides into the bloodstream. And this really looks very much as if it's contributing to the huge increases that we're seeing in the dementias and the other neurodegenerative conditions. These unfortunate microbial metabolites, we also now know that they have a direct effect on your nociceptive neurons, on their receptor sensitivities, neuroinflammation, and the blood-brain barrier. So this is a cocktail of effects which would be predicted to increase the incidence of chronic pain. And this is what we're seeing in adults. We're now seeing this increase in children as well. And in the last couple of years, again, we've seen a few studies which show, yep, this is probably the situation here, because if you put prebiotic fibers back into the diet, you see antidepressant effects, you see anxiolytic effects, and we're beginning to see reports that in adults and in children with chronic pain, by increasing the intake of prebiotic fibers, we're starting to see the first reports that this is going to be helpful in treating those conditions as well. Ultra-processed foods, very little prebiotic fiber. The more of these foods you eat, the more the brain starts to deteriorate. And we know that this is nothing really to do with, it's not an age-mediated mechanism. It does get worse as we get older. If you're eating a terrible, inflammatory, non-protective diet, we know that that doesn't have to be the case, because in vestigial groups who are consuming, amongst other things, far more prebiotic fiber, we know that the hippocampus, which is where neogenesis is taking place throughout life, does not atrophy in the way that it does in those of us who live in the so-called civilized or first world. It's not just the fact that neurons are dynamic. It's not just the fact that with every act of learning and forgetting, you're growing synapses and you're bringing them back. It's kind of a waxing and waning that takes place in the course of every day. But if you have neuroinflammation, and if you don't have enough prebiotic fiber, you have endotoxemia, you have neuroinflammation, at that point, the nerves become less adept, less able to grow out and form new connections, and they become more liable to be pruned. The connections become less. And eventually, if the nerves are exposed to this environment for long enough, that process of decay will move back along the retrograde, along the axon, arrive at the cell body, and kill the neuron. So this, we think, is one of the reasons why the ultra-processed diet tends to increase the risk of a decline in cognitive and executive function. So that's one thing that having the wrong microbiome, the microbiota, contributes to. The other thing that it's doing is leading to general inflammation, neuroinflammation in the brain, which destroys the extracellular matrix inside your skull, which leads to a deterioration of the architecture of the brain, the general architecture, the structure of nuclei and tracts. So it's not just the fine detail that's being damaged by not having enough prebiotic fiber in your diet, it's the macro detail of the central nervous system as well. I won't go into all of this because I don't think we have enough time. All I will say is that not enough fiber is strongly linked to an increase in polycystic ovary syndrome, and there is good evidence that taking more fiber will improve polycystic ovary syndrome. We have equally good data that shows that prebiotic fibers play an important role in affecting the risk of toxic preeclampsia. We don't have time to go into this, but I can answer questions about it later if anyone wants. We also know that it's involved with this decline in sperm counts and the reduction of testosterone levels, which people have probably seen me talk about before. Endotoxemia has been implicated in both of these things, not the only causative factor, but certainly one of them, and an important one. So what I'm trying to get across to you is the idea we don't need to do that. Oh, I will just talk about this. The second half of this slide, I promised you that I'd mention something about the mechanistic aspects linking fiber and breast cancer. The link there seems to be at the level of something known as the estrobolome. The estrobolome refers to all of those microbes in the lower intestine which act on estrogen metabolism. Now, if you have dysbiosis, you have more bacteria which produce an enzyme called beta-glucuronidase. You're producing estrogen, males, but obviously more if you're female. Some of those estrogen metabolites are moving into the gut. They are conjugates. If you have dysbiosis, the microbes there will deconjugate the estrogen, freeing it up so it then can be reabsorbed, and it means that your estrogen levels go up. And if you're still very, very young, that accelerates menarche. And if you're older and you have an estrogen-sensitive cancer in the breast, for example, it is more likely to accelerate under these conditions of high estrogenic drive, which dysbiosis contributes to. So there's no data yet to support this claim, but I believe, based on the available science, that increasing prebiotic fibers in the diet will be effective. It'll delay menarche and it will reduce the risk of estrogen-mediated cancers in later life. Now, I'm going to come back to this question, why the gut test, why it's important. And I'm going to finish with the influence of the gut on general health here, because I think, hopefully, I've made the case how important it is to ensure that your microbiome is properly configured and that your gut health is, at least in this respect, optimized. So we'll just finish off with this gut cancer connection. We know that if you have dysbiosis, this is very closely associated with a dysregulation of T cells in the gut in such a way that basically there are cytotoxic CD8 plus T cells which are involved in killing cancer cells. If you have dysbiosis, not enough prebiotic fiber, the number of these cancer-killing cells is reduced. So cancer cells in this complex cancer ecology, which would have been killed or kept in check, are no longer being killed. More of them are surviving. More of them are surviving to become a potential threat. What dysbiosis also does is it affects another group of T cells called T regulator cells or Tregs, and that reduces anti-tumor surveillance. So now you're not killing off cancer cells as much as you should, and you're not watching them as carefully as you should. What this means is that prebiotic fibers, they likely reduce the risk of cancer in the gut, and going back to the WHO study, they certainly do reduce the risk by at least 25%. But because these immunological shifts are relevant not just to the gut, but to all other tissues, prebiotic fibers almost certainly reduce the risk of cancer in many other tissues as well. And I'll just single out the gut and the pancreas, the liver and the pancreas, where I think the evidence is starting to emerge, but I think probably the brain also. So this is the modern diet. We have all the wrong population of cells, and we need to get back to that. To get there, we need prebiotic fiber. Now, no more details on the relationship between the gut and the health. There's lots of it, but we don't have time. I'm going to switch the slides now and quickly move on to the gut test, because what I hope I've done is to convince you that it is relevant to measure gut function. And I'm going to talk now about why we have chosen to look at the analytes that we have in the test. I want to give Martina Torresen credit for this. I may have started the ball rolling, and I've had some brilliant ideas as to how we could measure gut function. None of them worked, but Martina picked up where I left off, and she started looking at tryptophan metabolism, and that eventually formed the basis of the test that we are now using. So, as I've...
Paul, das Bild ist nicht weitergegangen, wenn du noch mal drauf drückst, bitte.
Oh, wait a minute. So let me stop the share. And what I will do, I'll start sharing again. My apologies. Okay, so are we there?
Das ist das geringste Problem heute.
Well, it tells me.
Ja.
Yeah. Okay. So a lot of these diseases are increasing. I mean, I'm so sorry, we haven't had time to talk about autoimmune disease, but that is very closely related to dysbiosis. The current model of medicine, which is basically a crisis management model, and is not appropriate to the task at hand, has not been particularly successful. We need to, I think, address the upstream issues, which we know drive these conditions, and they're listed here. You've heard me talk about them before, but I'm going to talk in particular about dysbiosis and about tryptophan. Now, tryptophan is really, really important amino acid. Yes, it's an essential amino acid. There's a handful of those. If there was one which was primus inter pares, more essential than all the rest, I think I would probably choose tryptophan. Because not only is it the key component in the microtubules, which are the internal communication systems that each one of our cells absolutely depends on, and which some people now theorize consciousness itself may be based there. Well, it's also involved in mood and immune function and in lots of other things as well. I'm going to spell it out here. Now, what most people know is the part of tryptophan metabolism that leads to 5-HTP and to serotonin, and then eventually to 5-HIAA, which is one of the ways in which we measure serotonin status, and melatonin, the sleep hormone. The serotonin pathway is the one that everybody knows, but this is only one of 3 major metabolic sequences. And this is one that is less well known. This is the indole pathway. And this is a sequence through which tryptophan produces a number of compounds, including IPA, which is one of the analytes we measure. IPA is very interesting to us because it is very anti-inflammatory, it is highly neuroprotective, and it has a number of other very positive health benefits. But then you have one other pathway, which is called the kynurenine pathway, which involves 2 enzymes. IDO is probably the more important, which takes tryptophan and turns it initially into kynurenine and then kynurenic acid, quinolinic acid, and that is a precursor for NAD, which of course is one of your prime energy compounds that every cell absolutely depends on. So IPA, this is on the good side, nominally the good side. I mean, they're both potentially good. It's a question of balance. IPA and some other indoles, it's anti-inflammatory, neuroprotective, as I said. It's chemoprotective. It's very good at stabilizing and killing cancer cells and forcing them to redifferentiate. But it is also mitoprotective. That is, it protects the structure and the function of the mitochondria. If you do not have enough IPA production in the body, you will develop mitochondrial inefficiency and eventually mitochondrial toxicity and dysfunction, which leads to the rundown of energy production in every tissue in the body, which is intimately concerned with the aging process, with the move towards death, and the move towards the loss of cancer control. Because IPA is a potent anti-inflammatory compound, it switches off IDO, which is one of the enzymes in the kynurenine pathway, so that the more you can promote the IPA pathway, which we do with prebiotic fiber, the less you have of the tryptophan going down the pathway towards kynurenine. So, more fiber, more IPA, you're protecting your mitochondria, you're protecting against the aging process in general, you're protecting against cancer, you're protecting against inflammation. Less of the right fiber, the bacteria which produce IPA, and it's a complex synthesis. A number of species work cooperatively to produce IPA. But if you don't eat prebiotic fiber, then you have more inflammation. Inflammation activates IDO, it activates the kynurenine pathway. Now you're producing more kynurenic acid, which is cardiotoxic, and quinolinic acid, which is mitotoxic. So these are really important compounds. They have a huge impact on your overall health. So you don't want to have too much kynurenine or quinolinic acid. They're both quite toxic. If you have mitochondrial dysfunction, you start producing more reactive oxygen species within the mitochondria. You start to accumulate more DNA damage. Your sirtuin metabolism starts malfunctioning. You progress towards immune failure and neurotoxicity. All this is well documented. There's a large literature. If you have inflammation of the gut and you're seeing an associated breakdown in colonic epithelial barrier function, they go absolutely hand in hand. You're going to see increased tumorigenesis and metastasis, not just in the gut, but elsewhere. You're going to see more neurodegenerative disease. So you want to promote the IPA pathway, and you want to tone down the kynurenine pathway. That is universally agreed on. Now, why do we have a kynurenine pathway in the first place? Because you need to have it to use acutely. It's highly evolutionarily conserved in different species. They all have it, so it must be important. And the reason why it is important is that it's a host defense mechanism over short periods of time during infections and certain other types of stresses. So if you have an infection, for example, you switch on an inflammation that switches on IDO, and now you start sucking tryptophan down the kynurenine pathway, and you are lowering levels of tryptophan in the blood system and in other tissues, and that in itself can suppress the growth of a number of different pathogens. So it's an acute defensive mechanism. However, if you overactivate it, and that's what we are now doing by taking prebiotic fiber out of our diets, you're producing far too much quinolinic acid, far too much kynurenine, and now it becomes extremely destructive. It's activated, overactivated, as I said, by dysbiosis, not enough prebiotic fiber, and the resulting chronic inflammation. Now you're depleting NAD depletion, and now you have a vicious circle kicking in, because as NAD is depleted, you get increased inflammatory signaling, and we move more towards mitochondrial breakdown, chronic inflammatory stress, and you move closer towards dying, disease, and death. Not a good idea. So the best thing to do, rather than taking IPA itself in a bottle, which some American freaks are now doing, I don't think that's necessarily a good idea at all. Its safety profile, in my view, has not yet been adequately appraised. Make your own IPA in levels that we know are physiologically beneficial. The WHO report supports that by consuming more of the right types of fiber. So here is the core disturbance. You have not enough fiber, you have dysbiosis, inflammation, you switch on IDO1, and now you're making more hydroxykynurenine. It's cardiotoxic. You're making too much quinolinic acid. At this point, it's directly neurotoxic, plus you are damaging your mitochondria. This is not where we want to be at all. That pathway is necessary at a lower level. Too much of it, absolutely no good at all. Here is the sequence of events. It's well documented. There's a lot of scientific research that has gone into generating this pathway. And it begins to explain, I think, the overall meta findings that very large WHO meta-analysis showed. More fiber, better health. Not just in terms of the gut, but in terms of a whole variety of tissues and a whole variety of pathologies. You achieve a significant degree of protection against all of them. Effectively, you are slowing the overall aging process. So the way to do this is increase your intake of dietary fiber, rectify the gut microbiota, produce your own IPA in situ, which deactivates IDO1, which downregulates the kynurenine pathway and reduces mitochondrial damage, immune damage, and inflammatory damage. And then I think what we might be looking at a few years down the line is we might want to combine this by adding NAD precursors. So you could get really fancy and include, nicotinamide riboside. There's a couple of others I'm sure you know of. Or you could simply increase tryptophan And that would bypass the QPRT block and enhance mitochondrial function all on its own and have a profoundly anti-inflammatory effect. So either by increasing dietary fiber on its own or possibly adding an NAD precursor, we believe that that would correct metabolic skew, reduce chronic inflammation, restore systemic resilience, and target very many health problems at their root. And we are measuring this through the new gut test, which measures tryptophan, IPA, kynurenine, looks at their proportions. And what we have already shown in pilot studies is that when we first test you, if you have a typical modern ultra-processed diet with very little prebiotic fiber, you will have low levels of IPA and you'll have high levels of kynurenine. When you start to add xenobiotic, and even more so, if you combine it with balanced soil and extend, all these things work together, you see the kynurenine levels coming down, the IP levels going up, and the ratio between the two, and the ratio each one of those has vis-a-vis tryptophan, starts to alter, and it shifts in a direction that we have every reason to believe is positive, and in a way which reflects the existing scientific literature. Has this test been validated? Partially. I would say based on historical data, we can say it's partially validated. Our pilot study supports that. The more people we test, and the more we are able to correlate test results with symptomatic outcomes, the better the validation will be. I believe that as this test becomes more widely used, the medical profession will come to realize that this is a quicker, cheaper, and more physiologically relevant way of testing for gut function than the current techniques, which use, for example, they'll look at microbiomal analysis, which I think it's complex. We don't really understand the results. And the microbiome itself is so dynamic, it shifts so much that you're just looking at one film of a long piece of film. And I don't think it actually tells you very much. People talk about the importance of diversity. Maybe. It certainly doesn't work in society. I don't think it works particularly well in gastrointestinal physiology either. It's a very crude concept. I think that this brings us closer to physiological relevance. I think we are now talking about a very deep aspect of the bacterial metabolism in the gut and its relationship with the GOLT and the rest of the immune system, which I believe is a coherent one. It'll consolidate as we do more of this testing. Will it survive? I hope so, but maybe someone else will come up with a better model, a better algorithm. If they do, we will learn from it. We will adapt and improve this system as we go along. This is early days. We didn't acquire this testing system off the peg as we did with the balance test. We developed it ourselves. And I'll be the first to admit that I do not think it is perfect predictive value yet, but as time goes by, our database will expand, and I think that the test will become more valuable. In a nutshell, ladies and gentlemen, that's where we are. If there's time for questions, and that's up to Jutta and Vibeke, I will do my best to answer your questions. Thank you.
Thank you very much, Paul. And we have got lots of questions, and it's impossible to answer all of them. But please don't raise your hand. It makes just a lot of noise. And I have been looking into the questions, and many of them are about different autoimmune diseases. Does it make any sense to take this kind of gut health test, and are there any benefits on using the health protocol or xenobiotic if they are going into, or if they have a severe autoimmune disease? And I don't want to go into the diagnosis, but can you say something in general, because there are loads of those kind of questions?
Yeah. Well, I have some ideas about this, but I see that there are many doctors in the audience, and I would be most interested to hear what they have to say. What I would say is this. Autoimmune diseases are characterized by intense focal chronic inflammation. And in most of these diseases, that is how the target tissue is progressively destroyed. It is a focal chronic inflammatory reaction. By using either immunosuppressants, such as the steroids, or by using less hazardous natural anti-inflammatory strategies, such as using balance oil, we know that we can reduce the intensity of this inflammatory reaction and thereby offer a degree of protection to the target tissues that are being damaged. We may, in some cases, be able to stabilize those conditions. We may, in some cases, based on what we are hearing, create a situation where the symptoms are no longer as severe and may not be present at all. I think that, to me, that is still only a symptomatic treatment. Let us consider the way in which autoimmune diseases form. Now, there are immunologists, and I am not one, who know the immune system far better than I do, who maintain that autoimmune disease is impossible. They say that there is another possible explanation for conditions such as type 1 diabetes, rheumatoid arthritis, SLE, and all the rest. There is a belief, and this really came from people working in rheumatology, that these conditions may not be, in the strictest sense, autoimmune at all. They believe that what may be happening is that Enterobacteriaceae, in this condition where everyone has, leaky guts these days because of chronic inflammation, are leaving the gut, moving in the bloodstream, finding homes in other tissues, and infecting cells in other target tissues. These are intracellular pathogens. So the cells that contain these new invaders, those cells are now expressing fragments of the microbes which are infecting them on their surface. The immune system is reacting to, as it should, to those fragments of microbes. They are foreign, they are causing damage. The immune system is trying to kill them, and it's inflicting incidental damage on the host or the target tissue. The evidence came from rheumatology because it was shown in a significant number of cases that rheumatoid arthritis could be, well, I use this word very cautiously, cured by using long-term courses of antibiotics, but only those antibiotics which are known to be able to penetrate intracellularly. And that, I think, was a very, very important clue. Now, there are problems, as I'm sure you know, with using long courses of antibiotics. They are extraordinarily disruptive to the gut microbiota in ways which may be long-term, which may have very deleterious effects. There is a new antibiotic, which some of you have heard me talk about, KIB 500, which is derived from cow's milk. It is effectively an amplification of one of the components of the innate immune system. It produces bactericidal metabolites, which have a molecular weight of between 70 and 80. They can enter cells very quickly and effectively. They can cut through caseation tissue. And for those of you who have an interest in tuberculosis, that is something you should take away from this. I have been collaborating with a number of doctors in various countries who have used KIB 500 courses of this over a few weeks, and it's completely non-toxic. It does not affect or disturb the microbiota. And they have told me that in some of these cases, the symptoms of the autoimmune disease have abated. Presumably, they think, and I suspect they may be right, they have removed those Enterobacteriaceae, which had got out of the gut, got into the tissues, into, let's say, the Langerhans cells of the islets of Langerhans, the beta cells of the islets of Langerhans into the synovial tissues of the joint, you're taking them out of the equation, the immune system now has nothing to react to. It now leaves the target tissue alone. I would say that this is not yet at the level of proof. What I will say is I have seen a significant amount of data which appears to be pointing in this direction. So, two phases here. To reduce the risk of autoimmune disease, maintain eubiosis, maintain plenty of prebiotic fiber in the diet. I have some evidence to back this up. I went to medical school in 1968. At that time, we were taught that autoimmune disease was rare and only about 20 of them were known. Now it has become an extremely prevalent group of diseases, and we know of over 120, and there are more appearing all the time. Over a time in which our intake of prebiotic fibers has declined dramatically, and we've seen this huge increase in autoimmune disease. That is not proof. I cannot say that that is a direct causative link, but we can speculate about mechanism, and it seems to make the beginnings of a persuasive case. When I add in the use of KIB 500 to achieve what look like very long-lasting, maybe even permanent cures of some autoimmune disease, it begins to look even more interesting. Now, for those doctors present, I simply offer you this hypothesis. I personally think it's probably correct. I cannot prove it. I'd like to know what you doctors think.
Well, there are some doctors who has been asking for scientific documentation, because when they are talking with their colleagues, they need to kind of, are you able to send over or do you want them to look into your blog perhaps to find that documentation?
Sure. I wrote a post which is called Autoimmunity, and some of these lines of argument are presented there together with the key references.
Yeah, so we can just show them your blog. There are so many questions, but many of them also includes SIBO.
Right.
When you do a test and you have bad results, and the recommendation is to use synbiotic, but they have problems taking the synbiotic, what do you recommend to do there? That's a question that many people are asking.
Right. Well, if you have SIBO, you cannot use xenobiotic. You don't want to encourage the metabolic activity and proliferation of microbes, even potentially good ones, in the small intestine. And this is why the University of Monash, a team there, I think 15 years ago now, developed the FODMAP diet. I mean, that's not a good treatment either. It sort of keeps things, it reduces symptoms, but that's not healthy for you in the long term. Because if anything, that's going to increase the risk of dysbiosis in the colon long term, and we know that's not good. So there is some evidence, not very coherent, but there is a case, I think, for using antiadhesins in washing these microbes out of the small intestine. And I first got a clue to this approach when I was reading some traditional German herbal monographs. And I came across a reference to treating something that I thought might be SIBO with carrot soup. And I remember reading that you have to make the carrot soup, you have to boil it until a slight sweetness emerges. What does that mean? It means that the carrot polysaccharides are being hydrolyzed to lower molecular weight carbohydrates. And that sounds to me as if they might be acting like, mannose in the urinary tract. You're displacing microbes which are attaching to the epithelial of the urinary tract. You're mimicking the docking sites that microbes use to latch on to the wall of the inner of this viscus to prevent them from being flushed away. And I always thought, well, probably something like that would work in the small intestine as well. The German reference to carrot soup got me thinking, and then I thought, well, why don't we try that in SIBO? And I recommended to various people with SIBO they try it. I got a lot of reports back saying that yes, this was very helpful. Now, I don't think it's going to work in every case. Nothing works in every case. I also think that if you have SIBO once, well, you can get rid of the microbes, flush them back into the large intestine. But why did you have SIBO in the first place? Maybe because you had ileocecal valve scarring. The valve is not patent, and so eventually the problem is going to reemerge. I mean, there are other things you can do to reduce the risk of SIBO. I stopped using proton pump inhibitors, for example. We have acid in our stomach for a reason. It's a physical defense mechanism, part of the innate immune system, so that those microbes you swallow are killed before they can get into the small intestine. And using proton pump inhibiting drugs is definitely linked to an increased risk of SIBO, and by the way, an increased risk of death from all causes. So these are not drugs that I like. If you can use instead gastric raft technology, that is a physical barrier. If that works for you, I think that would be preferable.
Thank you, Paul. And is it okay to ask you one or two more questions?
Well, seeing as it's you.
Thank you. You know, we have been over 2,036 attendees today. I think
Oh,
that's new record.
good heavens.
Yeah.
How wonderful.
Yeah, that's really, we just see that we are in a health revolution now when people really start to see what we can do with our test-based nutrition. So it's very exciting to see that more and more people want to know more and go in depth in what we do. So one question that also has been asked a couple of times is, could we use this gut health test to provide dietary guidance? For example, if the tryptophan level is low, do we know if it's the dietary intake, or can it be that protein digestion or absorption can be an issue? So,
Yes, absolutely. As I said before, this is a stochastic model, and these markers can be affected by a number of different things. If you have low tryptophan levels, it could be that you're not eating enough tryptophan, you're not eating enough of the right kinds of proteins. It's probably more likely that you have chronic inflammatory stress, and that is pushing a lot of tryptophan down the kynurenine pathway, and you're leaching the tryptophan pool for that reason. So that's why I said, look, if you take xenobiotic, you have more of the right bacteria to produce IPA, which switches off IDO1, which means less tryptophan goes down the kynurenine pathway. If you add balance oil, which is also switching off chronic inflammation elsewhere in the body, that will also downregulate excessive activity through the kynurenine pathway. So this is an argument not just for xenobiotic, it's an argument really for the health protocol in general. Now, when I designed the health protocol, I was thinking in an early way, in a preliminary way about some of these very questions. And so looking back, I think I actually got quite a significant amount of it right. I don't think it was optimal. I'm actually making changes to the design of certain elements in the health protocol in a way that I think will increase the production of IPA further. And that's clearly an important molecule, but which will also enable the body and the gut in particular to produce more urolithin A. Now, urolithin A is a very, very interesting compound, which is, I would say it's legitimate to call it a genuinely gerosuppressant compound. And you can make a lot more urolithin A if you have a correctly configured microbiome, but also a decent intake of ellagic acid. So that will give you a clue as to one of the directions in which I think xenobiotic is going to go in its next iteration.
That's really exciting. And I love that Cincino are adjusting the products with when new science come, when new findings comes. And the question I also have a lot here in the chat is, what are your opinion on using probiotics in combination with the xenobiotic, and also especially if you have been having antibiotics? And also the second was, there are a lot of people now on the keto diet where you do not eat other than meat, fat. So I don't know if you can go into those two kind of opinions that are out there and give us your opinion.
Well, I mean, let me take them in reverse order. Should we start with the keto diet?
Yeah.
I think that the keto diet is not configured in a way which is conducive to eubiosis. Does that matter? Well, if you are ketotic, you'll produce a lot of short-chain fatty acids yourself. So you'll produce butyrate in the liver, for example. So that makes up, for a part of the butyrate you would have made otherwise through feeding your saccharolytic microbiota. But I think that while the carnivore or keto diet is probably very helpful for some people in the short term, particularly if you have metabolic dysregulation and you have hyperglycemia and hyperinsulinemia, and you're overweight. I mean, going keto, I think, is a good strategy. I don't know if it's a very good thing long term. And the interesting thing to me is that there are very few cultures, if you look at the situation from a historical and anthropological lens, very few cultures, I can only think of one, that have lived for long periods of time on a keto diet. Most vestigial groups consume large amounts of prebiotic fiber. Now, the only group that I've ever come across that eats what looks like a keto diet are the Kikuyu. And they eat, famously, they eat a diet which it tends to be, meat and milk. But then, I mean that they're famous for that. And they actually combine the two in various dishes, which I've tried and which are take some getting used to. I just don't think, when you take an overview of vestigial diets in different parts of the world, I don't think that keto is particularly natural. And I think that if we shift to a keto diet, I think if we do it long term, I think there are health penalties. The other culture that is eaten traditionally a keto diet are the Inuit. Of course, not so much anymore, but back in the day they did. But again, it's rather odd. If you look at what they ate, not just fish, but caribou, and they would eat the caribou's stomach contents, which of course were plant-based. So I think they were consuming a certain amount of prebiotic fiber as well, maybe a significant amount. I don't know. I don't think I would recommend it to anybody today, long term. I think that we have become very vulnerable because the carnivore or the keto diet today is not what it would have been traditionally. There have been shifts in the nutritional profile of eggs and meat. Intensively raised and produced eggs and meat and milk are not what they were 100 years ago. That's shifted because the diet that we feed these animals on in the intensive farms now has changed a lot. The omega-6-3 ratio has changed considerably, for example. And if you're talking about monogastric species, that is reflected in the fatty acid composition of their meat and milk. Of course, if the species is plurigastric and they have the rumen up front. It doesn't matter what you feed them, because their fermentation system is at the front of the digestive system rather than ours, which is at the back. And so everything you feed in is broken down, and the microbes produce everything that the animal then lives on. So it's harder to manipulate the tissues of a cow, for example, than it is for a pig. Keep that in mind next time you go to the supermarket.
And then it was, do you recommend probiotics?
Yeah, well, now we run into the problem of colonization and resistance.
Mm.
The gut is very intensively colonized, and the further down you go, the more intensive that colonization is. And all the microbes in there, they're all fighting for their own little, place in the sun, or not in the sun, but you know what I mean. They have access to a certain niche, spatial distribution in the gut, access to different nutrients, both from the diet and also from the secretions into the gut. And when you introduce a relatively small number of lab-grown probiotic species into this mix, they don't take. And this was shown in a couple of studies that were done at the University of London 5 years ago. And if you feed people probiotics, you can detect the microbial species in the stool sample as long as you take the probiotic. But the day you stop taking them, they're gone. There's no trace to be found. So I'm not convinced that probiotics are all, the very good way of doing this, unless you're taking large amounts of them every day. However, if you've had an antibiotic course and you've reason to believe that your microbiome has been damaged, then take xenobiotic and top it up with, the probiotics of your choice. But probiotics on their own, I don't think will do much. Symbiotics, I think, are a better way to go.
Thank you very much. Now, I think we will let you go, Dr. Paul. I know you have been traveling over Atlantic and just landed in US, and we are deeply honored that you take your time.
No.
And,
Don't say
do
that.
all this
I'm just another
amazing teaching for us.
I'm just another working scientific stiff. That's all. There's lots of people who are doing this. But if that really is enough, then I'm going to climb back into my coffin and fall
I
asleep.
think you deserve that very much. And I
Thank
think
you.
all the questions we have got here, we might summarize all of this, and perhaps we could invite you again where we do like a Q&A on the questions that has come today, because gut health is a big topic, and people really want to dig into this, because now we have a tool that actually helps us understanding more. So thank you everyone for joining tonight, and thank you for your engagement. And this is just so an exciting journey to be a part of. And I'm so grateful for every one of you to join us on this global movement where we want to improve people's health with our test-based nutrition. Thank you so much, and see you again very soon.
Auf Wiedersehen.